I'm a dermatologic surgeon, as you know, and I'm specialized in skin cancer surgery and treatments. And I think, you know, a lot of times skin cancer is managed without necessarily the aesthetics in mind. And that's what I'd like to discuss here. Skin cancer, fortunately, is not a deadly disease, except in the unrecognized advanced cases of melanoma. It's about morbidity. It's about the local invasion, possible disfigurement, like in this man, the possible infection, the quality of life, and sometimes an improper treatment that leaves a bad scar. So when we're dealing with skin cancer, of course, diagnosis comes first. Even in aesthetic procedures, if you don't diagnose the problem, you'll never be able to treat it properly. But of course, with skin cancer, this is your typical nodular basal cell carcinoma with the crateriform erosion. At the same time, the patient who's a smoker who has the SCC, which is more of a verrucous plaque on the upper lip. But us, dermatologists, we should be very sharp and diagnose these lesions as early as possible. Like these 3 cases on the left, I wish I can use the pointer properly this time. Here's a plaque here. Here's another one here. And here's another one. You can see it on the eyelid rim. And this is where, you know, an astute dermatologist should be able to diagnose these lesions, because treating them early is very important to clear it well and to minimize morbidity and have a good aesthetic result. Unlike this patient here who was traumatized by a dental surgeon who extracted the tooth 40 years before he presented to us with this tumor. He extracted the tooth without local anesthesia. He swore to never see a physician again, but then eventually he had to come in because this tumor, they wouldn't allow him to go to work. And the thing with skin cancer, why is it important to diagnose it and diagnose it early, is that if unrecognized, it can spread tremendously. And this lesion here that appears to be quite limited, maybe about 1 centimeter, when we did Mohs micrographic surgery, so tracking those cells with frozen sections, you can see how much it has invaded the skin around. Obviously, the aesthetic result, fortunately for this patient, was good, as I will show you later, but it could be bad maybe in other cases. Melanoma is another diagnosis that's very important to recognize early on so that the treatment is done early on. We have high cure rates and we have good aesthetic results. So what is the armamentarium of our treatments for skin cancer? Of course, surgery. And most surgery, especially, are the gold standard when available. But of course, there are other options. Topical immunotherapy with imiquimod, lasers, photodynamic therapy, topical or intralesional chemotherapy with 5-FU, methotrexate are important. And these, personally, this is my bias, these are the tools that I use in my practice. I personally don't use cryo that much because I find it very aggressive and non-specific. It can cause scarring per se, can cause depigmentation. I rarely ever use electrodesiccation since my residency. Radiation therapy could be interesting for some lesions with the more recent developments in brachytherapy. So once you've diagnosed your skin cancer, I think it's important to use the most appropriate treatment. And why? Because it's okay, it's great to clear a skin cancer, but it's not nice to leave a scar, like with this curettage and desiccation on the left, a large red scarred area where there was exuberant curettage and desiccation, or the surgery where clearly too much was removed, too deep, and left an unnecessary scar, depigmented white scars on the face from excessive cryotherapy or radiation therapy for a large lesion on the back that still came back. As you can see, there's this dermatomal invasion of basal cell carcinoma going down towards the breast. So your treatment could be excessive, but still not effective for a lot of patients. So when we're managing those lesions, diagnosing, deciding on which procedure, deciding on which margin should be taken is very important. And taking little might not be enough. Taking too much might be enough, but might leave too much of a scarring. So knowing your size, being evidence-based with your approach is extremely important. Most surgery is very important, and before I mention, I'll show you this case, which was published in PRS when I was a fellow. The doctor was, discussing the technique of doing the myolabial flap for this, average size basal cell carcinoma. And this patient had to go to the OR, general anesthesia, huge flap, huge morbidity, and that's her a year later when had she had access to Mohs micrographic surgery, which we will discuss now, she would have a much less morbidity. It would have been done in the clinic under local anesthesia. She would have had a much better scar. So what is Mohs micrographic surgery? The whole principle is that we remove the skin cancer, and at the bedside, we have a laboratory where we can process the fresh frozen sections, examine the tissues, and we as skin experts were fortunate to work with Dr. Reem El-Bahtimi and her excellent staff to do our cases. So it's ideal for basal cell carcinoma, squamous cell carcinoma, lentigo maligna, fibrous tumors, angiosarcomas. So, and I'll show you some cases of how by preserving as much tissue as possible, we're able to get nice aesthetic scars. Of course, we all want to clear tumors. This is another tumor that had recurred 5 times before she came to me for Mohs, and you can see how extensive it was when we did the frozen sections. And when you do a normal pathology, when you send to the lab in a normal way, usually they're cut as bread loaf, and you're only examining 1% of the actual margin. When we do Mohs micrographic surgery, we're able to cut the tumor and see the whole margin, as you can see on the bottom slide. And if we show you some examples of, show you some examples of most cases before we get to the non-surgical. So sometimes we allow healing by secondary intention in certain areas like concave areas. We always respect the skin lines, no matter how large the area. If you respect the skin lines, you're going to have a nice result. Sometimes multiple lesions, we combine linear closures, small flaps, together get nice results. The aim here is that we have about 1 or 2 millimeter more margin than the actual size of the tumor. So we're not taking unnecessarily larger margins, which would lead to larger reconstructions. On the nose, a large experience with bilobed flaps, others, complex closures. This is part of the training, combining different modalities to not only clear the tumor, but get nice aesthetic results on the bedside. And when we cannot do a flap, we do a graft. We usually match the skin from the inside of the ear, the front of the ear, areas that resemble the sebaceous skin of the nose in that example. And we could even do a cartilage graft if there is loss of tissue in that area. And an area where it's really critical to do Mohs is the finger, the nail bed, where you see this SCC. In some books you would read that amputation is recommended. Of course, if you do Mohs, you're able to control the margin, make sure your margin is free, and then do what is necessary, a skin graft in that case. This is DFSP, fibrosarcoma protuberans, which is known to have tentacles that would spread significantly around what is visible. And you can see the defect here after Mohs, and that's the patient 6 years after it was done with no recurrence. The glans is a very critical area. Always, people come in panic because penectomy is often recommended for these patients. This here, I did PDT first to reduce the size of the lesion. Had to do insert a Foley in because there is swelling after the surgery. Did the skin graft, and you can see the area after 6 months. And here, another case, a verrucous carcinoma with HPV-16. Again, tissue preservation is key. When you do tissue preservation, you have a better aesthetic result, and for this man, it is life-changing. Okay, So the indications for basal cell and squamous cell carcinoma to do Mohs micrographic surgery, of course, not all lesions need to be treated. A lesion on the back, on the chest, a tiny thing on the neck might not necessarily be treated, but an ill-defined tumor, a tumor that has recurred or has been incompletely excised, tumor in that H zone or the butterfly zone of the face, a size that is larger than 1 to 2 centimeters in those critical areas. Of course, if there is pain, perineural involvement is an issue, or if you see it on your pathology report, or anybody who wants a smaller scar size. So again, an aesthetic result after skin cancer removal is important, then Mohs is indicated, of course, in the young patients as well. For melanoma, again, it's important to take the right margins. No matter where the areas are, as dermatologic surgeons, we usually can handle most of the reconstruction, but in melanoma, we often have to work as a multidisciplinary team. These nevi, it's not skin cancer, but of course, always the concern is not just aesthetics, but what if this turns into skin cancer? An excision with a nice reconstruction in this area. I want to stop maybe a minute to discuss congenital melanocytic nevi, because we've been seeing a few of those. What do you do with those? When you have giant congenital melanocytic nevi, by definition, it's more than 20 centimeter. Do you send it to plastics? Do you do nothing? Do you do laser? The risk, as we learn more and more in time, is about 8% with a 20 centimeter lesion, maybe 12% in 40 centimeter lesion. So 1 in 12 or maybe 1 in 8 patients is going to have a melanoma over their lifetime. So do you do surgery? Do you not do? It's always a lot of psychological trauma to the family. Of course, it's important to recognize CNS involvement and doing an MRI. So I had 2 patients lately that were very interesting. This patient who came in for reconstruction, he was exactly that little boy when he was a neonate, and that's him at age 14 after multiple surgeries, a lot of scarring. So presented for hair transplant. The plan is to do a bit of volume restoration to rebuild the symmetry in his face and lift his eyebrow. But he had to go through a lot of surgery when he was a kid, missed out a lot on school, and it was quite a heavy toll on him. On the other hand, this is a patient that I treated. She came to me from the south of Lebanon with this lesion for which she was not admitted at school. She was literally bullied by the school principal. She was not allowed to go there. So I had to give him a really serious call then. But look at her after 8 sessions of a combination of the fractional erbium plus a Q-switch 75, and then after the big explosion, we lost the 755, we replaced it with a 532. But it is a life-changing treatment using laser with no downtime, with no surgeries. And till today, no one has shown any issue with melanomas arising in those congenital melanocytic nevi from laser. You just need to be aware that if a melanoma will still arise, it might be amelanotic, and that's important to discuss with the family. So not every skin cancer needs to be treated with surgery, and we have a panoply of things we can do. As soon as I came back to Beirut from Boston, this is a new Mohs surgeon. They sent me this patient, 5 times recurrent of a lentigo maligna on the face. And I wasn't going to operate on it. I gave this patient a course of Aldara. And you can see this person a year after that course of Aldara clearing lentigo maligna, and there's enough literature on this for you to look up. Cryotherapy, as I mentioned before, is very effective for multiple AKs, but people who have numerous actinic keratoses don't necessarily want to have these white scars. And photodynamic therapy was initially introduced for skin cancer. At BU, we did this very study to show its efficacy for multiple actinic keratoses. And you can see that a large number of AKs that this person has are gone without a single scar, with less than 6 days of recuperation period, as compared to 5-FU and others, which I never prescribed personally. On the other hand, this patient with epidermodysplasia verruciformis who had multiple lesions. Of course, you're not going to operate on this person. You know, it will be very difficult to treat this area. I managed her with a combination of light curettage, photodynamic therapy on those lesions, followed by imiquimod. And you can see her 4 years later, all these lesions went away, but she developed another one, of course, as expected. What do you do with this large basal cell, superficial type basal cell carcinoma? Of course, you know, it would be criminal to operate on a lesion like this, which would never threaten the person's life. She's a 50-year-old, active, sporty lady. So lasers are increasingly used for these lesions. They address the vascular part of these tumors, and as you can see, as it is very red, it is very vascular, so you have enough chromophore to absorb, and there is, again, for those of you who are interested in the field, there's a lot of data on the vascular laser for treating basal cell carcinoma. And this patient, after 2 sessions, that's her 6 months after this treatment. She disappeared after this, but I would have maybe treated her with Aldara. This patient had radiation therapy for acne when he was young, and multiple pigmented basal cell carcinomas. You can see using the alexandrite in this case. Why the alexandrite? Because it targets the melanin, the pigmented part of the basal cell carcinoma, and you can see most of them are gone, and you know, he was lost to follow-up. A problem that we see often in the clinic is a new tumor that grows rapidly, that is extremely scary to the patients. Is it an aggressive SCC or is it a keratoacanthoma? And you know, when you have the experience, the clinical acumen, sometimes it's very easy to differentiate, but sometimes you have to take a biopsy and rely on a very good dermatopathologist like Dr. Reem, who's been amazing helping us with these cases. So this case here, by the way, is an invasive SCC, and you can see you know, how the cells are disorganized. Dr. Reem would describe them better. But in someone who is young, who comes in with an enlarging lesion on a critical area, would you do surgery on this 40-year-old lady who has this lesion that is crateriform, that has the border that is increasing, that is very suggestive of keratoacanthoma? This is what I did. I did methotrexate, and this is now an established treatment for keratoacanthoma. It takes a clear diagnosis that is supported by pathology. It takes a patient that understands what we're doing, because this will take time. It's several weeks until we do enough injections, 10 to 20 milligrams of methotrexate intralesionally, until the lesion clears. And you save these people surgery and possible disfigurement. So that's an extremely aesthetic result, yet we didn't compromise with the result itself. And this is a recent case that we saw in the clinic, also quite challenging. To me, it was clearly keratoacanthoma, and fortunately, it's at the last stages of healing. So managing difficult skin cancer doesn't mean you cannot keep the cases aesthetic, people looking good, so they're happy that they've been cleared from their cancer, but they still look their best, and they are functional. There is so many things that we can offer them, and I hope you found this a helpful session for you. Thank you.